much, Ilan, for the invitation. I'm delighted to be part of this very stimulating initiative, and it's wonderful to see all of you out there taking time out of your Saturday to be here. So I know I'm the last speaker standing between now and lunch, and so I'll try to make this as painless and hopefully exciting as possible. So as Ilan mentioned, my research focuses on the impact of public policies on social inequalities in health. And today I will be talking to you about the part of this research that focuses more specifically on private health insurance. And here, the case study that I'll be looking at is Canada, because I'm doing this comparatively internationally. So I like to put up this quote when I start my talk, partly to remind myself of it, but also because I think it indicates, okay, so just to give you the context actually, this was a quote, a response that was given to me by a senior manager at Statistics Canada when I asked this person in 2004 about the availability of private health insurance measures in our largest national population health survey. And this is what I got back. So welcome back, because I was coming back from a PhD in the States. Welcome back to Canada. We don't worry about health insurance here. Private health insurance, sorry. And of course, she kind of, caught me off guard, and I started wondering, well, maybe I'm wrong. Am I going the right direction? Darn, I should have taken that job at Berkeley, stayed in the US where they do care about private health insurance. But in fact, I think I put it up too because it's a common misconception that we have in Canada that the private sector is a trivial part of our health system, in the sense that this is not true, in the sense that we already have 30% of our expenditures that are coming from the private sector, not all from private health insurance, obviously. But also, we tend, those of us who have private health insurance, and many of you probably have it as supplementary private health insurance as students, we tend to forget what it means, and we tend to take it for granted and think that most everybody has it, when about 50% of the population doesn't have it. And so there is that sense that we have a universal health system. What's the problem? What's the big concern? You bleeding heart liberal. And so, this is something that I want to bring up. And in fact, when we look at this, looking back at this quote, 5 years and more than $1 million in grants later, I could tell you that some people care about private health insurance in Canada and the impact of that on health inequalities. And this is what I'll be telling you about today. If this is working? No. Okay. So, before I delve into the research, just give you a quick definition of what I mean by social inequalities in health. And here I'm putting up data from the Montreal region, looking at social inequalities in health over time, over a 10-year period. And so from 1986 to 1995. And what we see in here is that sorry, I'm still trying to make this work. Oh. Okay, so although we've had an increase in life expectancy for all the population over this period, what we also see is that the difference, so these inequalities, so the difference between the lowest and the highest income group, the lowest in yellow and the highest in the brown color, have actually remained fairly stable over time. And in the case of men, this is particularly striking in that we have a 5-year difference in life expectancy from the lowest to the highest income group in this tertiles that has, again, remained fairly stable. So there's a rising tide for all, but differences, these differences are staying stable. So that's social inequalities in health. What is causing social inequalities in health? Well, the web of causation, the etiologic web here is pretty complex. And here I'm just putting up one perspective, which is that of the social determinants of health that I worked under. And I can tell you right away that it's not genetics explaining this association, nor is it lifestyle or health behaviors, at least not completely. And so we need to look beyond that, beyond the individual characteristics of the population. And I situate my research at the broader sense of these impacts, which are the policy, the public policies. And something else that I'd like to highlight is that we have healthcare services here, but notice that they're not all-encompassing, and they're only one of the social determinants of health. So this is the one that I'll be talking about today. And more specifically, I want to talk here about the International Research Infrastructure on Social Inequalities in Health, IRIS, that was funded by the Canada Foundation for Innovation, and that allowed me to bring here to McGill data from 21 of 30 OECD countries to look at public policies in a comparative context. Why do we want to look at public policies in a comparative context? Well, as we learned, there are other countries doing things differently. And so we stand to learn from these experiences as well. But more importantly, from, let's say, an experiment, or I'm a social demographer, so I want to get that hard quantitative data. And from that perspective, it's very hard to run an experiment. We're talking about some of our most basic fundamental rights. And so let's say that I were to look at you, take this room and say, well, you have healthcare, you lose coverage. You have healthcare, you lose coverage. Every other person loses coverage in this room. I don't think that the Ethics Review Board at McGill would really agree with my proposal. So we are not standing to make the kind of perfect experiment where we would randomly assign treatment to individuals and just look at them a couple of years down the road. So the next best thing we have is to look at what we call natural experiments, when we use experience from other countries kind of as a counterfactual to what we have here in Canada. And so this is what I've been doing in the past couple of years. Here, however, I will only be talking about Canada because of, obviously, time limitations. But as you're listening to me here, you may be wondering, again, we have a universal health system. We know that private health insurance is fairly limited in its coverage. It's only, at this point in most instances, covering for supplemental issues. So it's covering for things like testing, maybe travel insurance that are not covered under the private system, under the public system. So what evidence do we have that it really makes a difference to health down the line? Because if these things are so important to health, then surely they would have been covered under our national health system. Just going back to a little bit of international evidence. What you have here on the slide is the proportion of private spending as total health expenditures and the healthy life expectancy, with higher, here being better life expectancy. And this is also looking, not just life expectancy, but looking at healthy life expectancy, which is really what we should be aiming for as a population, as a society. And what you see here, just broadly, is that those countries that have a greater proportion of private spending as a part of their total health expenditures are doing somewhat worse than those who have the least, in terms of healthy life expectancy. Now we can be happy Canada is standing just about here. So we're doing pretty good. But what we may be concerned about is going down the road to that end, obviously. And by the way, this is not the US either. We're not. The US is standing somewhere here, 65%. So, this is kind of the background, but really, what about Canada?